Hello and welcome. My name is Robert Brook. I'm a professor of cardiovascular medicine at Wayne State University, and I was the chairperson of two American Heart Association scientific statements on air pollution and cardiometabolic health. Today, I'll be briefly discussing and overviewing the topic of particulate matter air pollution and cardiovascular morbidity and mortality. The resource map and the keywords are available on the presentation. And we have 5 learning objectives that will take us through the concept of how climate change impacts air pollutant levels and then impacts human health. So let's start with a case study. Very briefly, we have a 72-year-old woman with a history of several cardiovascular risk factors, including hypertension and diabetes, who has chronic stable angina, who presents to the emergency department with chest discomfort and nausea. She had reported staying indoors during a wildfire smoke event and was tired of staying indoors and went out for a walk in the neighborhood, after which she started having chest discomfort 1 hour prior to the arrival to the emergency department. Her vital signs were fairly normal except for some hypertension. ECG corroborated an ST elevation, myocardial infarction in the anterior leads, as were also corroborated with elevated cardiac troponin levels. The diagnosis was an acute coronary syndrome, anterior myocardial infarction. The question then is what role, if any, did acute exposure to particulate matter air pollution play in her acute coronary syndrome and her myocardial infarction? So briefly, what is PM, or particulate matter air pollution? Particulate matter air pollution is derived principally from human-made fossil fuel consumption from regional sources such as coal-powered industry. Local sources and mobile sources were all principally exposed through traffic, but also indoor sources, cooking, biomass, and then as well as natural sources, which are increasing because of climate change, most notably from wildfire events. Particulate matter can be categorized by its sources, but also by its sizes. Principally, we talk of PM 2.5, which is particulate matter less than 2.5 micrometers in diameter, or in the size of bacteria. And that encompasses all particles within the nanoparticle range, all the way down to tens to hundreds of nanometers in size as well. It's a highly heterogeneous particle composed of sulfates and nitrates, element of carbon, but on the surface are many metals, transition metals, which have the ability to create oxidative stress in biological tissues, as well as organic carbon species, such as polycystic aromatic hydrocarbons, thousands of different organic species. Particulate matter can stay in the atmosphere for many hundreds to thousands of kilometers to be transported and stay in the air for several hours to several days. It's truly a regional-wide problem. Now, climate can affect air pollution levels in a complex manner. But basically, the evidence suggests that rising global temperatures associated with climate change can increase ground-level pollutants, including ozone and particulate matter. Climate change also plays a role in making wildfire events more frequent and more intense around the world. And then some of the particles themselves, including black carbon, as well as gaseous pollutants, CO2 and ozone, also further positive feedback and contribute to climate change. What are the impacts on cardiovascular health? Well, it's been well shown over many hundreds of studies that systemic responses are incurred by short-term exposure to PM 2.5 air pollution. It can promote systemic-wide inflammation, oxidative stress, alter autonomic balance by decreasing vagal tone and favoring sympathetic nervous system tone. And many of the components, particularly the nanoparticle size components, can even reach the systemic circulation and then embed themselves in the nervous system as well as cardiovascular tissues. End organ changes have been shown that occur very acutely, including including vascular dysfunction, acute high blood pressure, enhanced thrombosis and coagulation, acute atherosclerotic plaque instability, inflammation, as well as impaired cardiac functioning. This leads to acute health effects, including myocardial infarctions and acute coronary syndromes, particularly in susceptible people who have underlying atherosclerotic coronary plaques or plaques in other vascular beds. Acute strokes due to the atherosclerotic plaque rupture, as well as due to high blood pressure. arrhythmias, atrial fibrillation, as well as worsening of heart failure due to the systemic inflammation and hemodynamic changes. Perhaps more of greater public health impact are the chronic health effects. Long-term exposure, living in air-polluted areas for several years, plays a role in promoting cardiovascular events through those direct mechanisms, but also indirectly by chronically promoting the genesis of cardiometabolic conditions, including worsening atherosclerosis, progression of plaques, increasing the risk for development of high blood pressure and diabetes, and low HDL and dyslipidemia. There are several vulnerable as well as susceptible populations. One of note are that communities of color in the United States are well known to be exposed to higher levels of particulate matter. Various policies in the past, such as redlining and industrial zoning practices, have set the groundwork for health inequity as well as environmental racism, leading to higher levels of exposure, particularly in socially vulnerable communities as well as communities of color. And much of this has been shown to be linked to the increased risk for cardiovascular morbidity and mortality in African American communities and in communities facing greater social determinants of health problems. What are the implications for clinical practice? Well, the most important thing is, from a healthcare perspective, is to reduce each individual patient's underlying susceptibility. That is their risk of health effects from exposures. That's been well known to be done by controlling underlying cardiovascular factors, ensuring that blood pressure is controlled, diabetes, lipids are controlled, ensuring that patients face a healthy lifestyle of diet and exercise. There are personal level interventions that have been shown to reduce exposures, such as following the air quality indices, which are promulgated daily in various media sources, including the EPA airnow.gov, that provide activity recommendations based upon a person's underlying risk, whether they're a general population or whether or not they have underlying pulmonary disease, such as asthma or COPD, or underlying cardiovascular disease. Avoid local sources, such as near roadways, as well as indoor sources, such as fires and cooking. Indoor portable air cleaners with HEPA filters, as well as specialized HEPA filters in house-wide HVAC systems, have been shown to reduce indoor air pollution as well as personal level exposures by over 50%. And very susceptible or high-risk populations can dramatically reduce their indoor exposures by these measures. Wearing face masks, such as simple cloth or surgical masks, and even N95 or N99 respirators can be very effective in reducing exposures. However, their clinical utility in the real-world setting has not been established. Community-level interventions such as educational campaigns, increasing green spaces, and local ordinances can actually have a profound effect in reducing the risk of local pollution exposures. I think very importantly, there are several key roles for healthcare providers in this global battle against climate change as well as particulate matter air pollution. One is to serve as a trusted source of education for the public as well as individual patients on the health risks posed by particulate matter and climate change. To work with patients to assess their individual risks and adopt individual plans to mitigate the risk. To provide support for national ambient air quality standards from the EPA, as well as further PM and other pollutant regulations at a local level. To serve as advocates and for the importance of climate research and climate education and pollution education within medical societies, and to work for the reduction of the carbon footprint for themselves, as well as within the healthcare system. So coming back to the case study of the 17-year-old woman who had a acute coronary syndrome myocardial infarction, potentially triggered by wildfire smoke exposure or particulate matter triggered myocardial infarction, what would be a follow-up plan? One would, of course, be to control her cardiovascular risk factors to an ideal setting to reduce future susceptibility to particulate matter exposures. Provide education about the importance of avoiding high levels of particulate matter exposure in patients who are at risk for atherosclerotic cardiovascular disease events, and develop an individualized plan, such as following the daily AQIs on airnow.gov, staying indoors during severe wildfire events, including the purchasing and use of portable air cleaners in a bedroom, and a main living space. And then to reconsider any non-voluntary travel to heavily polluted cities in the future across much of the developing world where air pollution levels are much higher. So in conclusion, climate change leads to broadly worse levels of many pollutants, including particulate matter air pollution. Fossil fuel combustion is the main source of particulate matter air pollution in the modern day setting. PM exposure can acutely trigger cardiovascular events, but can also chronically promote the genesis of cardiometabolic conditions over the long run. Communities of color are disproportionately affected by air pollution and face disproportionate health risks and public health burden from particulate matter exposure. And healthcare providers indeed play a pivotal and important central role in helping to combat climate change and preventing the adverse health effects of air pollution. Thank you very much.